Good afternoon, everyone. Thank you for joining us. We're going to let folks populate the room before we get started here. Alrighty, good afternoon, and thank you all for joining us today for ITEP's Sacramento Issue Work Group, maintaining coverage for California's most vulnerable, unwinding of the PHE. My name is Emily Castillo, and I am the Director of Programs for Insure the Uninsured Project. Today, we will discuss preparing for the unwinding of the COVID-19 public health emergency, or PHE. We know that there are many aspects to the unwinding of the PHE, but today we are going to focus in on the Medi-Cal redeterminations of over 15 million Medi-Cal members. With us today are state and local government officials, consumer advocates, and local stakeholders doing the work of outreaching and enrolling / redetermining Medi-Cal eligibility. Before I hand it over to our first moderator to kick us off, I have some important housekeeping notes for you. This webinar is being recorded and will be available on the ITEP website. I'm going to go ahead and pop that link in there for you. Attendees can listen into the webinar through their computers or by dialing in using the number and passcode provided by the Zoom software. We also welcome you to utilize the closed captioning function. Just click on the CC button at the bottom of your screen to enable the live transcription feature. Today's webinar will run approximately 2 hours and will have 2 main panels, each followed by a question and answer session. If you have questions during the webinar, we encourage you to submit your questions using the question and answer panel, which you can also find at the bottom of your screen. When submitting a question, please indicate if it's directed at a specific speaker. We will answer as many questions as we can throughout today's webinar. Also located at the bottom of your screen is the chat panel. Please feel free to use this function to say hello or chat with other attendees. We will be posting relevant information and links throughout the webinar here. And now I'd like to introduce Marian Mulkey, ITEP's Interim Executive Director, to get us started. Marian?
Good afternoon, and thank you, Emily, and thank you, as usual, to the entire ITEP team for another timely and well-organized event. I'm really grateful to have the opportunity to facilitate this first panel of leaders in the Medi-Cal enrollment domain. And I come to this conversation with several hats, so to speak, a longtime California health policy observer and consultant, the current chair of the ITEP Board of Directors, and during what we expect to be a fairly brief interval, the interim ITEP Executive Director. Looking back to late January 2020, when the COVID-19 public health emergency was first declared, over that period of time, we can certainly all, I think, appreciate the importance of federal and state policies, including the suspension of annual eligibility redeterminations and all the related flexibilities allowed under the public health emergency that have allowed so many people to keep Medi-Cal coverage throughout the pandemic. These policies have, as I think we all know, brought Medi-Cal enrollment to an all-time high, and clearly many Californians are benefiting from affordable access to healthcare as a result. At the same time, however, we face uncertainty and some concern about what will happen when the public health emergency ends and eligibility review for a very large volume of people resumes. I know that today's speakers are all keenly aware of how the reinstatement of the eligibility review process will place substantial demands on enrollees and on the organizations and individuals who support them through the process. There's a real risk that some people will lose coverage and experience disruptions in their care arrangements, and everybody here is working as hard as they can, I know, to prevent that. This session will give us opportunities to hear directly from our speakers with updates about the plans and priorities that they and their organizations are making as we approach the end of the PHE date, remaining uncertain, but likely early in 2023. So today's panelists offer 3 crucial statewide perspectives on this topic. Sandra Williams, Chief of the Medi-Cal Eligibility Division at the Department of Healthcare Services, will present on DHCS plans for the PHE unwinding, including resources and timing considerations. Kathy Cinderling McDonald, Executive Director of the County Welfare Directors Association of California, or CWDA, will describe how counties are preparing for the PHE unwinding. And Alicia Emanuel, Senior Attorney, National Health Law Program, or InHealth, will describe how the PHE unwinding will affect consumers and will describe opportunities within the federal and state policy landscape for Californians to be supported through the transition. So the way we're going to run this is each speaker is going to provide an overview with some slides and data. And then we'll have a facilitated question and answer session. As Emily said, submit your questions via the Q&A panel at the bottom of your screen, and we'll raise as many topics as we can with the speakers during our time together. So Sandy, it's up to you. Please go ahead, and welcome again to all our speakers and to our audience.
Thank you so much. Again, my name is Sandra Williams. I'm Chief of Medi-Cal Eligibility here at the Department of Healthcare Services, and I'm happy to be speaking on this topic. I know that there are a lot of questions, a lot of unknown, and hopefully we can sort through some of that today. So, just a little background. In January, as you likely know, in January 2020, the U.S. Department of Health and Human Services declared a public health emergency in response to the COVID-19 outbreak. Shortly thereafter, the Families First Coronavirus Response Act, we do refer to that as the FFCRA, provided us with a continuous coverage requirement, which essentially said you will keep everyone on Medi-Cal, with very few exceptions, throughout the duration of the public health emergency. So beginning in March 2020, if you were on Medi-Cal, you continued to be eligible to Medi-Cal or continued to stay in coverage, regardless of changes in circumstance, unless the beneficiary was deceased, moved out of state, or requested a voluntarily requested a discontinuance. Now, the U.S. Department of Health and Human Services did renew this latest renewal just this month. The public health emergency has yet again been extended, and this will be through January 2023 if we don't receive any other extensions. So moving on, just resuming normal business operations. So when the public health emergency ends, and understand when the public health emergency ends, we're going to call this period of time after that the unwinding period. So you'll hear me refer to that throughout the session. So when the public health emergency ends, counties will be processing annual renewals on the beneficiary's next normally scheduled annual renewal date. So if a beneficiary had, let's say, a May renewal date every year in 2018, 2019, and so on, if the public health emergency ends January 2023, that's just an example, then in May 2023, that particular beneficiary will go through the renewal process. Now, what this means is counties will follow the normal business processes when completing the renewal during that unwinding period. This includes an ex parte review of any and all information available within the case without asking for anything from the beneficiary. We call that an ex parte review. And all cases will go through what we call the happy path or automated ex parte review, meaning we will send everyone's information to the Federal Verification Services Hub in hopes that many of these individuals will automatically renew. If their information is compatible with what is in the Federal Verification Services Hub, the beneficiary will get a message saying, congratulations, you're renewed for another year. If there is a discrepancy, again, we will look at the case, see if we can resolve any discrepancy before reaching out to the beneficiary. But if not, we will send a pre-populated annual renewal form only to the beneficiaries whose eligibility can't be determined through that ex parte, or for whom the ex parte would result in a discontinuance. So before taking any negative action, the counties will be reaching out to beneficiaries to sort out any discrepancies. Now, one population that we are, whose renewals will not be based on their normal annual renewal month, are individuals affected by the young adult expansion. As many of you know, California continues to expand healthcare for all, health for all, to various populations. More recently, the 19 through 25-year-olds. But we understand that some of these folks are going to be turning 26 during the pandemic. So in hopes of them not being without coverage, we are going to actually move their renewal dates to the end of the unwinding period. So they will actually have they will stay in coverage protected under the continuous coverage requirement, and we will renew their eligibility at the end of the unwinding period, likely December 2023, January 24. We know that there is the adult expansion that will cover 26 through 49-year-olds come January 2024. So this, in essence, will bridge that gap in coverage and keep these kids in coverage until the date, January 2024, in which they would be continued in coverage under the adult expansion. Okay. Next, eligibility sequencing map. So we take you through some scenarios here as far as renewal periods go. So once the public health emergency ends, the federal government has given each state 12 months to unwind all the flexibilities and changes that came about during the COVID-19 public health emergency, and to conduct, as we talked about earlier, conduct a redetermination of eligibility for each Medi-Cal member. States will have an additional 2 months to complete the renewals as long as the renewals began within that 12-month period. Additionally, states need to ensure that a redetermination of eligibility occurs for all beneficiaries within the unwinding period. So the 12 to 14 months is what states are being given, the time frame in which states are being given to process all renewals. States do have the option to redistribute the renewals across the 12-month period to meet these timelines. So there is not going to be, I mean, with all things being equal, we know that there may be some months which are heavy in renewals and maybe lighter in some other months. So states are being given the flexibility as long as you get all the renewals done within that 12 to 14 month period, we're good. As an example, let's assume that the public health emergency ends in January. Please bear in mind, that's just an example. We don't have any inside information, but that is when the latest extension takes us. If the COVID-19 PHE were to end in January, the 12-month unwinding period would begin in February 2023. County renewal processing would begin in February for the April renewal month. We always back things up 2 months ahead. Those individuals' information would be sent to the Federal Verification Services Hub for compatibility, and those who are reasonably compatible with the information there will auto-renew. And for those that don't, counties would be taking action, reviewing the case file, and then ultimately reaching out to the beneficiary if they couldn't sort out or resolve any discrepancies. Now, the last renewal month in that scenario would be March 2024, with the renewal activities beginning in January 2024. So we would, that our 14-month period would end March 2024, given a January 2023 end of the public health emergency. So resuming normal business operations, we did release a county PHE unwinding toolkit. This is a readiness plan, and we issued a MEDL that accompanied that toolkit for counties. The purpose of this toolkit truly was designed to help counties assess their own readiness in 3 areas of what we perceive to be high impact. So organization and staffing, staff training for all levels of staff who perform or supervise Medi-Cal related activities, and then lobby management, call center guidance, and outreach strategies. Counties are being asked to assess and self-attest to their readiness in these key areas. And DHCS is ready to provide any technical assistance, any assistance or help that we can provide in any and all of these areas and beyond. Now, we did, DHCS has been involved in an extensive outreach campaign during the COVID-19 pandemic. Medi-Cal enrollment has increased to over 14.5 million. I think at times we've seen enrollment at 15 million. And that represents an increase of over 2 million individuals. So once the COVID-19 public health emergency ends, understand that counties are going to be processing annual renewals that may result in individuals no longer qualifying for Medi-Cal. DHCS goal is to minimize any beneficiary burden and to promote that continuity of coverage for all beneficiaries that folks have been able to receive during the continuous coverage requirement during the public health emergency. This presentation, we have shown some of the flexibilities DHCS has adopted to minimize the burden on beneficiaries and hopefully provided messaging to help individuals maintain their benefits ongoing. However, DHCS is requesting all of California's help in this endeavor. How you can help is through the DHCS Coverage Ambassadors Program. The DHCS Coverage Ambassadors will be trusted messengers, if you will, made up of diverse organizations that can reach beneficiaries in both culturally and linguistically appropriate ways. Additionally, DHCS Coverage Ambassadors will connect Medi-Cal beneficiaries at the local level with targeted and impactful communication. DHCS will provide the communication toolkits necessary to be successful as a DHCS coverage ambassador. And these toolkits can be found at the DHCS websites that you see here on this slide. And you can also sign up for the mailing list to receive updated toolkits and information as it becomes available. We do encourage everyone on this call to become a DHCS coverage ambassador to help get the word out for millions of Medi-Cal beneficiaries who may lose coverage if we're not able to get through to every single one and make sure that we have the most up-to-date information. The counties have the most up-to-date information. So phase one for DHCS coverage ambassadors would be, well, the overall strategy is split out into 2 phases. So phase one has already begun and is geared toward encouraging beneficiaries to update their contact information with counties. The phase one toolkit includes flyers, social media, messaging, call scripts, website banners, and more to help the DHCS coverage ambassadors spread the word and the importance of beneficiaries keeping their contact information up to date with their county. In phase two, We'll be launching this 60 days prior to the end of the COVID-19 public health emergency. The federal government has promised that they would signal to all states at least 60 days prior to the end of the COVID-19 public health emergency. So we are all waiting for that notification. And once we receive that, we will be launching phase 2. We'll highlight that renewals will begin soon, and beneficiaries need to watch for the renewal packets to come in the mail and to update their contact information with their county office if they haven't done so already. Now, in anticipation of the end of the public health emergency and needing, to get the word out, understanding a communication and outreach campaign would be so valuable. The DHCS did, through the Budget Act of 2022, we did appropriate $25 million to seek a communications and advertising vendor to implement this broad education and outreach communication campaign for all of our Medi-Cal beneficiaries, both during and after the end of the COVID-19 public health emergency. We do anticipate launching this in November, just next month, with a vendor on board. And that concludes the DHCS presentation.
Thank you so much, Sandra. That was a great overview and really helpful. We're going to continue the conversation. Actually, I'm going to ask you one very quick question because It has been popping up repeatedly, which is just to clarify if there's any connection between Governor Newsom's recent announcement about ending the pandemic condition versus the federal determination around the public health emergency ending.
Sure. No, I guess in a nutshell, no. We are waiting for and do take our prompt, our guidance from the U.S. Department of Health and Human Services. So with regard to Medi-Cal eligibility, that is the entity we'd look to be the signal to launch all of the unwinding activities. Yes.
Yes, thank you. And since it was a
question from the governor's announcement
right now. Yeah. So let's turn now to Kathy Cinderlin McDonald, who's going to talk to us more about the role that counties are playing and how they're getting ready for all this activity. Kathy.
Unmute, that would help. All right, hi, can you see my screen okay?
Looks great.
Great, thank you. Hi, everybody. So I'm Kathy Sunderling McDonald. As I said, I'm the Executive Director of the County Welfare Directors Association, CWDA. We represent all 58 county human services agencies. So I'm going to talk a little bit about just some context setting from the county perspective, about some of the things that we've been doing that you've already heard some about from Sandra on the county and CWDA engagement. Some information on outreach and information sharing, and then just sort of step through a couple of potential, for lack of a better word, pain points that we might look out for as we see the unwinding occur. So first, just thinking about setting some context. Of course, the county's role in Medi-Cal is that counties play a critical role. Our county human services agencies conduct eligibility determinations, they manage clients' cases, process annual recertification. So of course, that's been largely on hold during the past 2.5 years, and respond to clients' programmatic inquiries each year. Just, do I need to renew? Am I eligible, but I haven't yet applied, and that sort of thing. So during the PHE for almost 3 years, the Medi-Cal beneficiaries, as you know, have not had their Medi-Cal benefits discontinued or reduced, even if they did not submit paperwork or reported changes that would have otherwise made them ineligible if it were not for the PHE. However, we know that people's lives are not static during the PHE. They also might receive other benefits, such as CalFresh, which doesn't have a similar PHE set of protections to go along with it. And this has required counties to perform a variety of creative workarounds to preserve Medi-Cal coverage while taking appropriate and required actions in the other programs that are often received by the same individual or the same household. We at CWDA have worked alongside the counties, DHCS, CDSS as well, which oversees CalFresh, CalWorks, and other programs to plan accordingly, knowing that the PHE would eventually be lifted and we would begin this unwinding process that Sandy was talking about. And so when the PHE ends, we anticipate, as you heard, that all Medi-Cal beneficiaries will need to have their eligibility redetermined over the following year. We've been thinking about it in a 14-month time frame because you get sort of that first couple months to start up that process, like Sandra was explaining. And due to the length of the pandemic and the economic impacts that may have significantly changed the beneficiaries' financial circumstances, as well as even just their addresses, as you were hearing, and as many of you have probably experienced and helped people with those changes in their lives as well. Those are things that could also then have an impact on their eligibility when we do that redetermination. So what have we been doing to get ready for this? Since early last year, CWDA and our counties have been engaging with DHCS, also our automated systems that are collectively known as the Statewide Automated Welfare System, or SAWS, and individual counties and representatives to understand the potential workload impacts of the unwinding and to begin planning for that associated work. One of the reasons we started so long ago is none of us really knew how long this would take to get to a point where we were either well enough past the pandemic or well enough into what is, of course, considered now more of an endemic situation with COVID, that the PHE would ultimately be lifted. There was discussion last year before the surge that it might be last year that the PHE was lifted. And so we started talking together and really appreciate the state's partnership in this a long time ago to start thinking about what workload, what processes, what automation changes that would entail once that really did finally happen. And now, of course, we have this sense that we're on the cusp of it, though we don't yet know for sure just yet. So counties have been having monthly meetings for the planning and the resumption of our normal operations. We coordinated with the counties to identify representatives with a good cross section of size and location to represent their sort of fellow counties and work groups for that effect. And we've also been working with the SAWS about the automation changes that would be necessary to prepare for the lift. And so the idea is to process our cases and generally apply changes as they would have just regularly come up for their annual renewals. That's the sort of simplest way to track people in our systems, is we key a lot of things off of that redetermination date. So I think there were some early concerns on the part of counties or the advocates that perhaps everybody would get a packet at the same time, or it would be done in some other way that was a little less logical perhaps than how we usually think about people's eligibility being based on that calendar and when their redeterminations are due. And so because it's really just, I think, key to minimizing risks to workload, to something else that's going on at the exact same time that we're doing all this work, which is migrating into a single automation system called CalSAWS that's likely to still be going on in the midst of the work of unwinding also getting started and occurring, and to facilitate that whole overall resumption of the normal case processing, just basing it off of the redetermination date, like Sandy showed you on that chart, just makes the most sense. Of course, with the caveat about things like the adult expansion that she talked about in her presentation. And so, which we supported and agree with the process that's being taken. We also are looking at and really appreciate the state going for some flexibility for counties and doing some of the determinations. There are some things about when our systems look out to federal systems to see what's someone's income that they have reported. What does the federal government hold in its database, and how does that compare to our database? they could be out of sync. It's been so long since changes happened. And so making sure that we are being as flexible as possible and what we define as reasonably compatible. And we give people enough time to provide explanations where there are discrepancies is something that we think is extremely important as well, and appreciate, again, that partnership with the state. Additionally, we worked with the Department of Finance, Department of Healthcare Services, and the legislature to provide state funding for counties. That started in the 2021 governor's budget, and it's a 2-year amount of funding. So counties started spending that in the prior fiscal year, continuing into this current fiscal year, and we'll be continuing to monitor that. Did we hit the mark? Are we a little underfunded? And this is, I think, a good response too. Now, I saw a question pop up in the chat. Are we going to staff up? Yes, counties can use this funding to staff up, do training, bring in overtime workers, kind of whatever we need to do to be able to manage that extra workload. And in addition, there's going to be a lot of training going on. Counties are going to be providing refresher trainings for our eligibility staff on topics related to the PHE, such as renewals, enrollment activities, how to deal with a change in circumstance. These are things that some of our workers have never even actually had to do because they're newer to the program. And if they came in during the pandemic, they've been trained on these things, but they haven't actually experienced doing that. And so doing those refresher trainings and making sure that they know about what they're doing is important, as well as, of course, participating in the DHCS trainings that Sandy mentioned, which are accessible to county staff on an ongoing basis. So a couple things just to piggyback. I mean, Sandy did a great job, I think, explaining the ambassador program. We have sort of a couple things to just mention that I really wanted to highlight for this group. First off, our goal is really to try not to panic our recipients, to not make them think that everything's happening at once, that they miss getting something in the mail to the point where they're going to call their worker. Our workers are going to get a lot of calls, as you might imagine, over the next year plus, whenever this lift occurs and the actual work starts happening. And so we want to make sure that people are only calling if they need to tell us that something has changed. If they've been living in the same home or same apartment the entire pandemic and they're receiving mail from counties regularly, they're good. You know, they don't need to call just to check in. They don't need to call if nothing has changed and they get those materials. They should call if they need to tell us that something has changed. And so nuancing that message is pretty important. Our key advice, if you have updates, and then when we start to send the renewal packets, fill out and return the renewal packet if you actually get one. As Sandra mentioned, we're going to be trying to go down the happy path and do the ex parte automated renewal for as many people as possible. And if it works, someone will get a letter that says, congratulations, you're renewed and here's your next date. They don't need to do anything. It's only if they get that communication that says, we couldn't find you eligible based on this process, here is what we need from you, then we really need them now to pay attention. And that gets me to my last slide, which is about the pain points. This is a huge mindset shift. We've had people who have potentially never even been on the program when they've needed to fill out those things. So it's a shift from, no, don't do anything, you're still getting materials, but you can ignore them, to you may have to do something. If you get something from the county, you really do need to act on it now. This is going to cause confusion, so messaging is key. If you get something, fill it out, send it back to the county. And we do know, finally, the other pain point is just that county workload is going to really skyrocket here. On the Medi-Cal side, we've been largely an intake operation for the last 2.5+ years. CalFresh, in particular, has been where we've been getting so many new applications. We're going to be shifting back over to do all of this work in Medi-Cal. And we also know that we'll likely see a lot of state hearing requests as people are found ineligible or perhaps have had changes in their coverage levels. And so our state hearings division, which is housed at CDSS, along with our county staff, will be working together to try to figure out how to streamline and potentially staff up as well those operations. So that's it for me. Obviously, we'll get your questions in a few minutes, but thank you so much for the opportunity.
Thank you so much, Kathy. Again, a really helpful overview with a nice mix of big picture and very specific advice to your potential partners. So thank you so much for that. We're going to turn now to Alicia Emanuel from National Health Law Program. Alicia, we are looking forward to your comments as well.
Great. So as Sandy said, once the end of the public health emergency happens, Medicaid's continuous coverage provision, which helped many people stay on coverage, will come to an end, and states will need to resume processing renewals and performing regular Medi-Cal operations. Through this process, it's anticipated that millions of individuals and families could lose coverage. Some reports project that across the country, over 14 million people could lose Medicaid coverage. And here in California, it's projected that roughly 2 to 3 million people could lose coverage. A recent report by the HHS Office of the Assistant Secretary for Planning and Evaluation predicts that across the country, approximately 8.2 million Medicaid enrollees will leave Medicaid due to loss of eligibility, and an additional 6.8 million are predicted to lose coverage despite being eligible because of administrative churning. And administrative churning is essentially just paperwork, having difficulty navigating the renewal process, states losing contact with beneficiaries, and other administrative hurdles. This is why public education, outreach, and advocacy is critically important now and once the public health emergency ends. Next slide, please. Thank you so much. I just wanted to point out this data from the ASPE report. It shows projected loss of Medicaid eligibility. Again, this is national, because of ineligibility, which is in blue on the graph, versus loss of coverage due to procedural reasons, which is in yellow. So ASPE projects that a large number of Medicaid beneficiaries will drop off Medicaid for procedural reasons, like having difficulty navigating the renewal process, as I mentioned, and particularly with kids. You see here on the graph that they anticipate that roughly 72% of kids who lose coverage will do so because of procedural reasons. So this is something we just need to keep an eye out for. Next slide. Similarly, this data point projects that a disproportionate number of people of color across the country will lose Medicaid once the public health emergency ends. In particular, it's projected that of Latinx individuals who lose coverage, 64% of them will lose coverage for procedural reasons versus only 17% of their white counterparts. Another way, Latinx individuals are predicted to be over 1/3 of those predicted to experience administrative churning or dropping off for procedural reasons, even though they're still eligible. So this is all to say that as we enter the public health emergency unwinding period, advocates, community partners, and state officials alike will need to be mindful of ensuring that individuals with limited English proficiency, people of color, older adults, individuals with disabilities, and families of children on Medi-Cal have the support that they need to navigate the renewal process once the public health emergency ends. Next slide. Thank you. So we're going to talk through what action you all can take. Next slide. So as Sandy and Kathy mentioned, you can sign up to be a coverage ambassador. This will get you on a listserv so you can receive prompt information and materials about the unwinding. Across the country that some people aren't clear about this point, particularly since the media has all but declared the pandemic is over. And then as Sandy and Kathy touched on, continue to advise beneficiaries to update their contact information, like their mailing address, their phone number, their email, with the county welfare office. A lot of Medi-Cal beneficiaries have moved in the last 2.5 years, and many low-income Californians continue to experience housing insecurity. So we don't want a changed address to be the only reason that someone drops off of coverage. And then continue to help beneficiaries report changes. As Kathy mentioned, have them contact the county if they need to report a change. So if someone has an income change, if beneficiaries reported information maybe during the public health emergency and they're not sure if the county got it, and or if they need to report new information, they should contact the county eligibility worker directly and outside of their renewal packet. There are multiple ways to contact the county. So calling them, writing a message online, and if people you are helping don't yet have an online account, now is a good time to create one. And then one other thing is that, not on this slide, but you can remind folks that they can find out now when their renewal month is by looking at their past renewal packets, so that they're clear on when this unwinding process will happen for them. And last, if you are an advocate looking to collaborate with your county, as mentioned earlier, each county is required to develop a county COVID PHE unwinding readiness plan that will be submitted to the department. And so you can contact your county to engage in that work. Next slide. And then once the public health emergency ends, what are important things you all can do? So, continue to advise beneficiaries to watch their mail and their online accounts for renewal forms or other notices they might be receiving. The department has also said, and Sandy can speak to this more, that they will be providing renewal information in yellow envelopes to the extent they are available, and kudos to them on this. This will help flag important information in the mail for beneficiaries. And as much as planning, is involved, it's inevitable that some individuals will erroneously fall off coverage. And even for those who are no longer eligible for Medi-Cal, they're going to need support understanding their health coverage options. So keep connecting beneficiaries with the entities that can help them get back on Medi-Cal and transition to other coverage they might be entitled to, like Covered California coverage. It's also important to make sure that beneficiaries understand their rights during this process. And then overall, just continue to educate your communities about the PHE unwinding and important action they may need to take, and continue to lift up your concerns to DHCS and or other partners like NHELP, who meet regularly with the department on PHE unwinding efforts. You all know best what the needs of your communities are. Next slide. Okay, so just lifting up two resources, but there are many. The Health Consumer Alliance, of which NHELP is a part of, is a consortium of legal aid entities across the state that provides free legal assistance to help people struggling to get or maintain health coverage and resolve problems with their health plans. Our website, as well as the toll-free number, is available there. And the slide also includes a link to DHCS's Navigator project, and that will be updated with new Navigator contact information across the state once that is finalized. Next slide. Okay, and I just cannot stress enough how invaluable the work is of all of your organizations, all of the work on the ground to inform Medi-Cal beneficiaries about these upcoming changes. Just keep building a network of helpers. In addition to all the state and the counties are doing, you know, advocates, CBOs, promotoras, community health workers, physicians and clinics, pharmacists, schools, faith-based organizations, and managed care plans are all integral to the success of the PHE unwinding process. And, you know, we do hope to see the department continue to do the great work it's doing to partner with and fund CBOs and assisters to support real-time communication and feedback loops with folks on the ground. Next slide, please. Just wrapping up here, I've provided some resources. NHELP has a PHE unwinding landing page with a lot of advocate issue briefs and resources we've developed, including the next one you see here, which is a checklist for redeterminations. So if you're an advocate or work at a legal aid organization and want more intel, you can go there. And then some, there's some information about our friends at Georgetown CCF who've developed a 50-state unwinding tracker. So you can check here how California is doing relative to other states, and then some DHCS resources. Next slide, which is my last slide, is just my contact information and how you can reach NHELP on the web. That concludes my presentation, and thanks for bearing with my technical difficulties.
Thank you very much, Alicia. We didn't miss a beat. We got everything we needed, and thank you for sharing that overview. So there was a follow-up question, which Kathy helpfully answered already in the chat, around what are procedural reasons for falling off of Medi-Cal, primarily being around losing contact with people or not having them respond when there is outreach to try and get them to confirm information. Would you want to add anything to that, just in terms of what you meant by procedural reasons, or is that a pretty good overview?
No, Kathy covered it well. Yeah, it's all the paperwork, all the losing contact with beneficiaries. And I think just because of what I highlighted about people moving a lot during the pandemic, people experiencing housing instability and experiencing homelessness, that this is a pain point or a concern for us, but that's why getting the word out is so critical.
Thank you. So I want to go ahead,
Mary,
Kathy.
would it be all right if I followed up on one thing that I saw, another question that I think is relevant to do right here?
Sure.
With all those moves, I did see someone put in the questions about intercounty transfers, that it can take a while for those intercounty transfers to get processed. And that's true, especially if someone's moved multiple times. What I would suggest, if you're helping a client who's got an ICT that doesn't seem to have been processed, remember that you don't just have to call the county that you came from. You can also work with the county that you're living in now. Because this is an automated process now, counties can, we call it the receiving county, you know, the county where the person moved to, can actually initiate the transfer in the system if it's not already been initiated. So it would be, you're not just limited to calling the old county, you can also talk to the new county. And I'd encourage taking the time now, while we're still in the situation where all is forgiven and we're in the PHE, to try to let them know, contact again. I know it can be frustrating, but it is a process that is historically tricky and sometimes does fall through the cracks. So now's the time. Don't just sit. I'd say go ahead and give it a shot for that person who put that in the chat.
Thank you. That's a helpful clarification, and I noted that question as well. Thanks, Kathy. So I want to kind of try to connect the dots, and I might be doing this not quite right, so that's why we have expert panelists here instead of me, between the observation from Alicia's national data that children in particular and Latinx people might be expected to not succeed as frequently as some other subpopulations, and the notion that you're doing your very best to do as much through ex parte and happy path as you can. And I'm wondering if that is in part because the data for kids is not as easily linked together. So that's a question. Is that a inference that makes sense? And more generally, how much do you have a ballpark guess about how frequently it is that the electronic or the ex parte renewals will be feasible for either the population as a whole or for subgroups of the population? And maybe I would start, well, any of you could take this, but maybe I would start with Sandy. Do you have a thought about that?
Yeah, of course, of course. I do want to start out by saying California has higher income limits for children. Number one, much higher income limits for children. So certainly that population would be more apt to fly through the auto ex parte or the happy path redetermination pathway. But aside from that, we are making sure that we target our marketing at the most at-risk populations and connecting with some trusted sources like schools to make sure we're connecting them from every source. Does that help?
Yeah. And Kathy, do you want to add to that?
Sure. I mean, I think we're expecting and we're already seeing, I mean, on the ex parte question and why will it not work as well? It's because it's been so long. And so the information that we have in our computer systems is likely to be, is more likely now to be different from what the feds have. And so, you know, counties are trying to take, again, advantage of this time to do some cleanup of cases to the greatest extent possible. But we are having to be very careful with that because, like I mentioned earlier, if somebody has a different case open in a different program, if you're trying to kind of manipulate the system a little bit, you don't want to do anything that could mess up what you've got. I mean, we programmed, I mean, our automation system was able to make a lot of programming changes very quickly, and then we had to tweak them here and there. But you just we're like in a stasis. So I think sometimes you get a little nervous about starting too early or somehow triggering something that you don't want to trigger. And I think so, but it's important to know that we have been the counties never stopped actually running redeterminations. That's why people kept getting packets for the last 2.5 years, or in some cases, letters saying, congratulations, you've been renewed again. Those processes didn't stop, and none of the noticing or mailings were suppressed because DHCS and the administration wanted to keep things as clean as we possibly could. We knew it wouldn't be perfect, and we get further from reality for a lot of the cases, but at least for those that did still go down that happy path and got that automatic renewal, at least we'd be done with some number of them, right? And in a situation where you've got 14+ million people, having a couple million knocked off and good is good. Like we're okay. The numbers are just so huge that it is a help to the workload, I think, if we can do that. But we do know from what we've seen is that we have had a lower percentage over that time of cases meet that ex parte no more needed. And so it's not going to be as robust as it was early on pre-pandemic, before we kind of had to shut all that other stuff down. So that's just so we know it's a lower number. It's not zero for sure. And again, any that we can get renewed and done and happy and we don't need to talk to you, the better. So we can minimize that traffic and really focus on the cases that we need to try to help people respond, help get the information updated and that sort of thing so people don't fall off when they still are eligible.
Just to piggyback on that, I did want to say DHCS has, well, for good or ill, become very adept at monitoring losses of coverage, throughout the PHE. So just wanted folks to understand that DHCS will continue to monitor very closely losses of coverage and, keeping track of any trends or huge swings. We have the ability, because we have, been working with counties and the SAWs throughout the pandemic to make sure that folks aren't losing coverage. So keeping a close eye on that through the unwinding period.
And by that, you mean, Sandy, just tracking how many people are currently connected to coverage over time. And if you were to see a decline, that would be
an unexpected
take action.
Yeah.
And what action would what would that look like?
We would work with counties and SAWs to do some, exploring as to what the reasons might be for that. Just understanding that we aren't going to be operating in a vacuum, that we'll be working with our county partners and SAWs just to see if there are any, anomalies.
Got it. Thank you.
Uh-huh.
Oh, and can I just jump in? I'm sorry, anticipating a question. We also, through the ex parte process, look at other information we have in our own system. So someone receiving CalFresh, for example, we could use information from that to help inform that eligibility renewal as well. I didn't want to make it sound like it was only going out to those federal systems. And I realized that and wanted to hop in. Thank you.
Thank you. So a question for all of you, and maybe I'll start with Alicia this time, is around any populations that you are particularly concerned about or sort of prioritizing. And I think this links to a question that a number of people had about community partners and how do you really take advantage and meet people, with trusted resources where they are. So the question is, who among all the people might be more likely to be overlooked or lost through these procedural reasons in this renewal, and how can you step up and partner with them to support them? And each of you I'm interested in hearing from, but Alicia, if you don't mind starting.
Yeah, I'm happy to start. I think I mentioned in my presentation, but there were, acutely concerned for people whose primary language is not English, for people with disabilities, for older adults, and other populations, people of color. And I think that, the department has done a great job in terms of releasing the materials available in all Medi-Cal threshold languages, and doing other things. And we also just know that it will impact populations disproportionately. And so I think that's why it's critically important to make sure that we have the, boots on the ground, so to speak, the hard work that many of you all are doing on the ground, and making sure that there's a communication pathway from the department down into the communities, which is, the ambassador program, and also that there's a communication pathway from your churches and CBOs and community clinics back up to the department as things pop up during the unwinding period. Yeah.
Thanks, Alicia. And maybe that's a nice segue to you, Sandy, around the communications and advertising that you're talking about. Are there ways in which that is maybe being targeted or modified for some of these populations of particular interest, or is that likely to be a statewide effort? Unmute.
That's a very good question. I have what I refer to lovingly as my external hard drive, who happens to be on the line here for all PHE related items, and the coverage ambassadors and the communication vendor that we are securing for this actually happens to be on the line, Teresa Hasbrook.
Hi, I'll jump in really quickly and answer and just say DHCS is very, very committed to making sure that the marketing that goes out and the folks that we're reaching with this campaign are truly the individuals that need to hear these messages. So we're going to be modifying as we go through the PHE unwinding and pivoting based on data, both data that the department has, as well as just some analytics about who we need to reach, what messages they need to hear, what are the best practices in really reaching those messages, the particular population. And, In addition to that, really making sure that our stakeholder partners like Alicia and Kathy and many others are really at the table as we're designing this campaign so that we're sure that it really represents the individuals we're trying to reach.
Thank you, Teresa and Sandy. And Kathy, when you think about resources and reaching populations that might be more vulnerable or a little bit less, a little more marginalized, how do you think about the role of the counties in addressing their needs?
Absolutely. I mean, certainly all of our communities where English is not a first language for so many of the recipients is huge, and something that counties do try to hire workers from those communities. And I will say, for those who have a foothold, are part of an organization, I think going to partner with the counties, but also thinking about whether you may know someone in the community who is looking for a job, who might be interested in being part of that eligibility staff. Most counties are going to be hiring new staff. And so there may be opportunities that you want to take advantage of in this time to try to hop in there and be part of that team. I would really encourage consideration and referrals and recommendations of people who speak the language and who are familiar with those communities would be a really good suggestion that I can make.
Yeah, and I think we're going to hear more about this in our upcoming panel. So thank you for that. One of the questions, and we're rapidly approaching the end of our time, which always happens in these great panels with people who know so much. One of the questions that has come up has been around prioritization of the renewals versus the other workforce demands at the local level. And this is probably a question for you, especially Kathy, but I think also just in general, how do you manage to keep the ship running on all the usual fronts while dealing with this upsurge in demands due to the reauthorizations?
Well, first of all, did I mention that counties are hiring? We definitely are, kind of doing our best to bring in new cohorts of workers. Now is the time to do that as well, because there's a training component, of course, before you just turn someone loose to process those cases. Those of you on the line, I think, based on some of the complexity of some of the questions in the Q&A, I do think we have some county staff. So both you understand that as well as know that you need some help too. So I certainly, encourage participation in that process. But I'll just say counties have always had to do that. I mean, think about the Affordable Care Act. That was really a focus on thinking about how to keep the front door open as much as possible for the really extremely large deluge of applications that had just been pent up in order to do that. And so I think the question might have been, well, then what are you doing on the back end? I think counties have long had to strike that balance. We try to work really carefully with our labor partners locally and at the state level, with legislative staff, with obviously DHCS and the administration, to try to not have anything lapse. That said, it could be difficult at times depending on how much is going on. But I think a couple of things that could help here are knowing the numbers, hopefully having as many of the cases handled through the ex parte as possible, and also we've been encouraging counties to take use of the time when they do have extra hours on hand for any of their staff to try to do case cleanup, to take a look. One group of cases, I mean, we've had a lot, like Sandy said, they're pretty good at the state level at noticing if there might be a group that we need to tweak our automation. And so not so much recently, but earlier in the pandemic, there were some groups where something was automatic in discontinuing, for example, due to some reason, and nobody had really picked up on that. And we're, oh, oops, we got to go back. So we, put everybody back on, no harm, no foul to them. But that means that they are pulled out of our usual automation. And so they're not in a batch process. And so counties are going to have to go in and manually touch those cases to kind of get them back in. And so trying to take as much advantage as possible to do that during this time is important for counties. And we've tried to remind them of that. I know, Sandy, you and your team have as well. And so just trying to kind of continue working together and staff up as much as possible. And then everything is a priority. I mean, we need to keep the front door open while we're also processing these redeterminations. And so counties are certainly going to just do the best they can to try to balance those ends of the system, along with the regular case management. A kid, a child is born. We need to make sure that they're covered and that sort of thing. So it's a lot, but we kind of balance it. So do our best.
Thank you. So we have come quickly to the end of this panel. I really appreciate all the expertise that you all offered and the resources you offered. And I want to especially underline the resources that Alicia ended her list with. I think a lot of people on this call will find themselves turning to those and looking for both data and updates from those sources. I know that DHCS continues to engage regularly with stakeholders and make data available as well. And I know that you all are working together, which is a great comfort when external observers like me think about how this set of challenges will unfold. So I know that our audience thanks you all as well for taking time to prepare and be with us today. And we appreciate all the dedication and hard work that you're bringing to this challenging time. So with that, I'm going to introduce the facilitator of our next panel, who is Heather Bates. Heather is the Chief Operating Officer and Vice President of Stakeholder Engagement for the health policy consulting firm Transform Health. In various roles, Heather has supported outreach and enrollment activities and campaigns in California and around the country, I understand. And she brings a rich set of experiences to this panel, which is going to highlight local perspectives in supporting consumers through the unwinding. So Heather and the panel, thank you for being with us, and I will turn it over to you, Heather.
Thank you, Marian. Can everybody hear me okay? Just need a sound check. All right.
Sounds great.
Great, thank you. Before we get started, I want to take a moment to introduce our couple of experts that we have. We're going to do this facilitated discussion style. So I'd like to introduce the two of them who have agreed to go along on this journey with us today. First, we're joined by Dana James. She is Staff Services Analyst, Healthcare Programs with the Humboldt County Department of Social Services. So we want to thank our county Medi-Cal offices today on this call. I think that's the lesson that I'm taking away. So thank you, Dana. And then we're also joined by Thomas Pham, who is VP, Vice President of Strategy at the ever famous Inland Empire Health Plan. And so I think we have the perspective of a county and a health plan today. And so I think that we've heard just from our prior speakers, which was an incredible panel. Thank you all for that information. I was furiously taking notes. I know everyone else was. So thank you for really setting this up nicely. The way we're going to approach our panel today is, number one, we recognize that all healthcare is local. When you hear all of these presentations, the first thing you're going to think is, well, how does it affect me, my people, our population? So we're going to go way down into the rabbit hole now and talk with our two expert panelists from their perspectives about how to approach the problem solving, proactivity, and planning that needs to occur with the PHE unwinding, as we will call it from now on. So with that, I think what we'll do is get started and just get right into it, because I know I was tracking some of the questions. I brought some of them into this chat as well. But essentially, just to get us going, from both of your perspectives, we'll start with Dana, then we'll go to Thomas. Dana, what do you think is the best way, based on everything we've heard and what you know at the county, to ensure that people who are enrolled now through the COVID-19 pandemic, public health emergency into Medi-Cal, what do they need to do to make sure that they stay enrolled from your perspective?
Essentially, the biggest piece is to make sure we have current contact information. If we can stay in contact with you, that's going to go miles and miles to helping you stay covered, even if we have to transition you to a different type of coverage. As long as we know how to get a hold of you, then we can work with you. Opening your mail is critical. You know, a lot of people will just put it in a pile, especially too right now, where we're sometimes sending out mail, but we're not really taking negative actions on the things that are in those packets. It can be a little bit, and then we're going to suddenly change it and say, oh no, you actually needed to turn in that one. We're starting now to really hit home with people. Stay in contact with us, and you need to start opening your mail. And if you have questions, you need to contact us. That's the most critical piece. The other piece is, and I've started, especially with Governor Newsom's announcement, and then our latest extension. I personally have started reaching out to entities that I know in the community where I've built relationships with them and asked them to become ambassadors. And I've told them, you can get in as deep or as shallow as you want to. Even if you just put up a flyer, it will help. A flyer saying, you know, you can do a benefits Cal an account, and it'll make it easier for you to renew your Medi-Cal. It'll make it easier for you to communicate with the office. You won't have to, you know, because we are severely staff shortage is a big deal right now. And so I will admit that the call times with the call center, the wait times are a little bit extended, and people are getting frustrated. And so we are doing the best we can to make people aware of the other avenues they can use to communicate with us. And that includes Benefits Cal and report and changes through that. So we're really advocating that a whole lot. That we're also there's some outgoing messaging when people call the call center. Our automated voice response, reminding people that they can report changes in Benefits Cal, and you know, keep your address updated. And anytime we come into contact with somebody in office or on the phone, we are automatically telling staff, please confirm that their contact information is still current. Every single contact. So, and then we got the outreach paperwork that was returned to DHCS. DHCS sent it to the counties. I personally went through all of that mail, contacted people, try to re-engage and make sure people are where we think they are, or if they are not where we thought they were, where are you? You know, do we need to do an inter-county transfer? What do we need to do to keep you on? So, but the biggest piece for beneficiaries is just open your mail and keep your contact information current with your county.
Thank you, Dana. I would be remiss if I didn't bring it up again, but we heard in the other panel all about the DHCS toolkits and resources online. I think we can put those in the chat again, just in case anyone is joining us late, because I agree, you know, being an ambassador, getting the word out, making sure there is no wrong door, to bring that phrasing back from ACA implementation is a really good way to go about it. So Thomas, let's go to you. I know there was a question earlier as well around what are managed care plans doing to ease all of the transition around the PHE unwinding, as it's being called. But I think more importantly as well, we want to hear from your point of view in terms of what someone enrolled in Medi-Cal should do, needs to do with the managed care plan to make sure that they don't lose coverage.
Thanks, Heather. So great to be here today. And as we hear from the prior panel as well at Dana here, right? The number one that factor that help the Medi-Cal enrollee to keep the benefit is to maintain the up-to-date contact information with the county. So from the health plan perspective, that every day we have our member contact us. Right? We have member contact us. And then every day we do some mailing or we do some contact with our member that, those opportunity for us that we receive significant like incoming call volume from the members. So for all those call, we verify the address. and verify the contact information, get the consent to send to the county for the county to update the information. And then, for us, we work with the post office where we able to get a list of our member who, when they move, they file a notice change of address with the post office, but they don't notify us or the county. So we get those lists, and then we outreach to those member and to verify their move, and then get those information, and then we share with the county. And so we also using the texting information to reach out to those members and obtaining the update information, and then we share with the county as well. So through all my mentioning that you hear the term county all over again, because that is the key. I think from the health plan perspective is that in order to make this work, we have to partner with the county, because ultimately county is the one who maintain the eligibility case for our, for member Medi-Cal enrollees. So, bring them to the table, co-create the solution with the county. Whatever we do here, it's not new to the county. County are not surprised. Whatever we do here is both county at the table, same at IHB. We co-create a list of solutions that we need to do, and we implement that. So we have many more initiatives that we partner with the county. One of the initiative is data sharing, Heather and Dana. You may do it at your county as well.
We do.
County very graciously, our county, we just appreciate the partnership with the county, that every month they share with us the data on, for example, a member who will be up to renewal, go through the manual renewal process 60 days in advance. So that allow us to plan ahead of who we need to outreach and help those members to renew, because that not everybody have to complete a renewal application, because from the ex parte, from the Happy Path, only a certain population, I think about 50% of population that actually need help. And with the partnership with the county, we know exactly who they are, 60 days in advance. That where we can do, work with the member, plan out to work with the member and help them to renew the process. So there are many solutions that we co-create with the county on the whole PHE unwinding effort.
Thank you for that. I think that's important to know that managed care plans are coordinating with counties on this. I want to unpack two things though. One follow-up to that is, if you're not a managed care plan, this may be for you, Dana, what is the best way to coordinate with the county? Is there a best way, or is it just geographically dependent? Is there anything you can recommend there in terms of being able to coordinate, partner with one's local county to make sure they are serving as a proficient ambassador? Anything you'd recommend?
Well, so we operate on partnership, and we get lists. I think we get them monthly, possibly quarterly, but monthly, with address updates and that sort of thing. And the bulk of our people are connected in with partnership. If they aren't, direct connection with the county would be the best bet. However, so in Humboldt, we have what's called a community liaison, and the community liaison will reach out to our clinics, to our hospitals, to HICAP, which is the health insurance counseling and advocacy program, our PACE program people, our adult services people, and we reach out, and the community liaison provides them with a lot of information, and we have pretty regular conversations with them, so that the people that they're coming in contact with who may be vulnerable to falling through the cracks, it's a little harder for them to fall through the cracks. And that's how a lot of that is how we stay in contact with the people who are in the super remote rural areas, because they're connecting with the people that are in their little area. And so we've made a concerted effort to reach out to those entities and to stay in contact with them. They have a direct email address where if they have general program questions about our policies, our procedures, hey, what is going on with X, Y, and Z? You know, if it's not a case specific, but a general, you know, what's going on in the business world of social services, they have a direct email that they can contact. All of our program analysts are connected to that. So if it's a Medi-Cal question, you know, and this, because we have one person who's the liaison, but if she can't handle it, she passes it to me. If she can't handle a CalFresh, she passes it off to the CalFresh analyst. So we're all working together to keep the community and the community, our CBOs connected with what's going on, and because we want to keep people on who need to be on, and if we can touch them, as you know, some people are like, for example, like in Hoopa, which is one of our Native American reservations, some people are going to be more comfortable speaking with Kamal than trying to like deal with the county. So we have, you know, the community liaison who can deal with Kamal. Like we just really tap into as many different entities as possible to stay in contact with people in as many different ways as possible, directly and indirectly.
Great. No, I think that's great advice. So anybody on this call who can't go through a managed care plan, definitely find your community liaison in your county Medi-Cal office. Thank you for that. And I want to go back to something, Thomas, that you said, I think that is really a twofer, which is obviously we need, you know, access in as many languages as possible. And DHCS has done a fantastic job really providing that platform to work from. But are there things that we need to consider as ambassadors, as, you know, partners who need to help make sure that we're getting the word out with regards to language, you know, appropriate ways of translating this? Just anything you want to add there in terms of the outreach piece?
Yes, from the health plan perspective, you know, we are, you know, I think most, and then I think all health plan, you know, provide the language interpreter services as well as translation of the material in different threshold languages. So the language system is there, you know, so at the community or advocate or community partner CBO, you know, would like, you know, they facing any of those question or challenge from Medi-Cal enrollees, always highly encourage them to contact the plan, and that where we have the interpreter services like on the line to, they don't need to make an appointment for that. You know, the service is on the phone, and they can get immediate help from that. And, you know, there are many material already translate in different languages. And Heather, you know, part of the platform you mentioned early on, and Dana talk about that, you know, the partnership for the advocate or the CBO that doesn't have a formal relationship with the county. What we hear from our county, that there are two things that you can help. Number one is that highly encourage Medi-Cal enrollee to set up a benefitcount.com account. That really helps significantly, because what the Medi-Cal enrollee can do, they can update their contact information directly on that portal, so it go directly to the county. Because when they contact us at the health plan, we will get that information, and then we send the information to the county. So there is another step in the way, right? So with the benefitcount.com, they able to do directly into that account, and it go directly to the county to review. And also through the benefitcount.com, they can literally renew their Medi-Cal in there and avoid all the mailing, everything. So that benefit count is very important for, you know, for the Medi-Cal enrollee to do. Secondly, is some of the county, I think many county now using the state provided texting platform that, you know, our county encouraged us to promote their texting program to our member to opt into the county text program, because that really helped. The reason is that when the county send out a Medi-Cal renewal application, our member, we get alert, a real-time alert that, hey, the packet on the map. So they get alert on the real-time eligibility. So those two things is regardless that, you have a formal relationship with the county or not, no formal relationship, county will really appreciate those two things that we all can do: set up the benefit telecom and promote the texting program for the county.
Those are
So-
great. I thank you for adding that context. I also just want to echo something in the chat that relates to health insurance literacy and health literacy, which is more illustration, less words, right? Picture of a person opening things. The ability to have that also as someone who's really providing advice and help to another person is just as beneficial. I know I'm a visual learner, so I always appreciate a picture. And speaking of, Dana, I don't know where your background is, but that's stunning.
It's here. This place is gorgeous.
Thank you. So, but I do want to go back to something important that seems silly, but is actually really relevant. And in the work that we do across the country with outreach and enrollment, one of the main things that I think we're seeing too is that, you might not know that you have Medicaid because of COVID-19, because of the public health emergency. Is there anything that you would advise folks working with these groups to look for, be on the lookout for specifically? I think we heard something about a yellow envelope earlier. Is there anything from the health plan or county perspective that you want to add to that point, just to make sure that we can triage, because everybody's got workforce issues. Although I really appreciate those at the county level right now, but I know we are all facing similar situations. Is there a way to triage that so that we can help the most vulnerable first, if need be? Is there anything that you would advise from your perspective? If not, we can move on. Dana, why don't we go to you first?
Again, it's just going to be like, I know that there was the coverage specifically for COVID related issues, and that was not administered on the county level. But if people somehow got enrolled in Medi-Cal and it continued and they're not aware of it, I would think with DHCS's outreach mailings that they've done, and they've done a few at this point, that would kind of trigger, and it's telling you to contact your county. And then once the unwind period starts and they get the renewal paperwork, that will be their flag. But in the meantime, again, I mean, we're doing social media stuff. We're doing, I think they're going to do some radio stuff. And again, we're really, really utilizing our CBOs. So who can, if they have somebody in their office who doesn't know whether or not they have Medi-Cal, they can actually, either get on the phone with us, or if they can sign a release with the customer in the office and get it to us, we can let them know whether or not the person has medical coverage. But it's really, everything is sort of tied into mail and looking at your mail.
And that texting and Medi-Cal.com account, right? Let's get that out there. Thomas, anything you want to add to round that out?
Yeah, so Heather, that's a question, but also I think that's a great suggestion to the state. Is that do they want to do anything different to the envelope of this time around, 2023 annual renewal? The reason is that for the last 2 years, they may mail stuff, they may not mail stuff, and to the audience, unintentionally, we may create a new behavior because what they in the last 3 years, they didn't do anything. They still able to keep Medi-Cal. So now why I have to do something? So in a way that you're right, in a way that we have to find a creative way to get them to open that envelope and respond, because last 2 years they don't have to do anything. So that's really a good question, but I think that great suggestion to state to consider.
And we heard it's tricky, right? I mean, it's you stay, you're enrolled, don't do anything, and now you have to take action, which I think is exactly why we're having this session today. The other thing I want to ask about has to do with sort of in relationship to receiving care. And I think this might be, something we plan to flag in for folks to understand, to look out for. But if I do have Medi-Cal and I just want to make sure that whatever my procedure is, whatever my doctor's recommending can continue into what's happening to me next, is there anything that you recommend as an ambassador to check for from your point of view, if you have any recommendation there? So we'll start with Thomas, since you are with Inland Empire. So basically, if I have a medical procedure, but I'm being told I have to renew my Medi-Cal, or I have to look ahead to figure out some other way to get what I need covered, what should I make sure I'm doing from the perspective of a Medi-Cal beneficiary?
Yeah, I think that's critical for them to keep the eligibility, right? In order for the continuity of care, they have to maintain Medi-Cal eligibility in order to do that. And that where, at the plan perspective, that when we get the data from the county that's showing 60 days in advance of our member who have to go through the manual renewal process, what we do, we set alert throughout our entire system. So we set alert for the department when they're doing that. We set alert for the member services department. We also set alert on the provider portal. So when the provider check eligibility for the member and see that they have a renewal date, then they would help our members. So it's great coming from the provider community, right? I think the message was stronger from the provider community to the member. So we are setting up, so everything is setting up. So, when the PHE expire, we just turn on the switch. So that's from the health plan perspective. That's what we do.
That's great. I think that's just important for us to plant a flag in to, as we start to talk to people about this. Dana, did you want to add anything to that?
I think one thing somebody might want to do if they have a procedure scheduled or something is just, and they haven't renewed their Medi-Cal, they may want to call to see when their renewal month is, so they can plan accordingly. Make sure they get that paperwork back to us. Realize that if they get that paperwork back to us, chances are it's not going to be worked the day we receive it. There will be a little bit of lag time. It kind of, that's the reality of it, is that they'll have a little bit of time there and they can have stuff taken care of. And who knows, their coverage may just continue. But what's important is to stay in contact with the county and make sure you if we ask for something, turn it in on time.
That makes sense. Yeah. And we know just from other experiences, you might live in two worlds, right? Depending on the date of service. So
right.
Make sure know where to bill, right?
Exactly.
I think is important for advocates to think about as well. So thank you for that. I would be remiss not to bring up Covered California in our day together. Fortunately for us in California, unlike some other places in the country that we heard about vis-a-vis NHealth, we have a state-based exchange here that does provide coverage. So I think another thing to know is that DHCS and Covered California have been working together to make sure that if somebody does lose Medi-Cal eligibility, they're potentially going to be eligible for a plan through Covered California, potentially at a zero premium. So Thomas, would you like to talk a little bit about that process from a health plan point of view? The floor is yours.
Sure, I'm happy to share what I know. I'm not sure I'm the SME on that, but I have fortunate time to learn from Covered California how it worked. At this point, what the auto enrollment process looked like, and in a way that during the annual, from my understanding, is that when at the point of annual renewal, when the county review the case, the eligibility case, and identify that the member income is no longer eligible for Medi-Cal, but they are eligible for Cover California. So there will be a documentation in the system that allow the state to extract the data and communicate that to Cover California. And then Cover California will auto enroll them into the lowest cost, the plan with the lowest cost, silver plan. And there will be notice sent to those impact member, and the member will have to say yes. You know, all they have to do if they want it, and then they will be enrolled in the plan with the lowest cost silver plan.
Perfect. Thank you. Yeah, and I forgot to mention, I do have a trusty colleague on the back end entering things in the chat for us. Sarah Beth Zemmel is our policy manager, and she just added some resources for folks around the auto enrollment process from DHCS to Cover California, our state-based exchange. So I think it's just important to know that people are going to be getting a lot of information, and it's possible they might even be getting it from our state-based exchange. So ITUP folks, we're looking at you to have a follow-up on this session, because we are only scratching the surface of what's to be and what we know right now. And as mentioned in the first session, the PHE unwinding is set to happen sometime in January as of today. But we know from public health that when you're in a pandemic that becomes endemic, you might face other changes as well. This is what we know to be true right now. There is a question that is coming up around LA County, and I'm not sure if our panelists can speak to this, or if someone in the previous panel would like to, but there's some difficulty creating Benefits Cal and getting through to, I guess, the county. The wait times are pretty long, and it can be 2 hours or more. Do you have a recommendation for folks in counties that are large where they just don't have the staff yet to really be responsive in a timely way? Is it setting up the Benefits Cal account? Anything else recommended? Dana, why don't we go to you?
I honestly can't speak to that because all of our CBOs go through our community liaison if they have issues with setting up accounts. So even though, we have 35,000 Medi-Cal cases, we somehow manage to do okay with it as far as CBO accounts and helping them navigate setting up accounts and that sort of thing. They don't have to go through the call center. They can just email our community liaison for assistance, and somebody will either call them or email them back.
Got it. And what's the wait time for the call versus the email on average with Humboldt?
Like 24 to 48 hours. That's for the CBOs. Now, if you're a beneficiary calling through the call center, it's a whole different kit and caboodle. It depends on what our staffing is that day. It's been like this, but we are doing continuous recruitments, and the Board of Supervisors did just approve a pay raise increase for eligibility staff. So hopefully that will bring in some more people before this whole unwind thing happens. We're just like hopeful we can get more staffing in so we can handle all of these things.
I think we're going to need a workforce edition of this that is both job recruitment and here's what's going on. So I'm making a plug for that. So just want to do two more things. We have another question about philanthropy in relationship to, if either of you can speak to this, if there are any other capacity building support or, other needs that might be required at the local level to help meet the moment and meet the demand that you would recommend from your perspective. I think it'd be great to hear from Thomas, then we'll go to Dana.
Yeah, that's a good question, Heather. And actually, that's exactly what we are doing with our county. So, our county came to us and we all recognize that's a staffing recruitment issue, right? Statewide at the county level. So how to increase the capacity. So that's what the county did, is that they train us to use the benefitcount.com account. They train us how to create the account. They train us how to navigate the account. So what we do is that we take in those knowledge, we build out our own team that kind of like we put together a team of 50 people, 50 people that all they do, call our member, help them set up a benefitaccount.com account for the county. So in a way that count. So if you are a CBO, you are, an advocate, county, you reach out to the county and county can train you on that. And you can literally help the consumer or your client to set up benefitaccount.com that they don't have to call the county to get help to set up that account. You can, on behalf of the county, can help the member and set it up. So that's what we do right now with our county.
Great. So maybe there's a philanthropy role there to also add resources to support that kind of outreach. Dana, did you want to say anything else?
I actually wanted to add to what Thomas was saying about the training piece. YouTube has Benefits Cal instructionals. So if you don't want to deal with calling to the county or you're not connected with your county, it's available. That information is available with screenshots and all kinds of good stuff. So that is also an option, not to be overlooked.
I love it. Social media. I'm going to ask ITUP if they can share that resource with everybody around the screenshots and get the word out about how to help people with that. I know that we are running up against our time, but I want to give our speakers the last word. So we've covered a lot of ground today. In the first session, we talked about, what is happening with the PHE unwinding from a policy standpoint, what's going to be the message to consumers, what is requested of all of us here in California and nationally. But given the local perspective that this panel has taken, I both want to thank you and appreciate both of you for the hard work you're both doing. It's tremendously helpful and very much needed, and we need to clone you both. But I'm
working on it. I'm trying to create, the one thing about having this influx of new staffing who haven't worked Medi-Cal is I get to mold minds. Yeah, so
influence them. Yes.
Yes.
Well, Dana, why don't we give you the last word? Thomas, then you, and then it's back to ITUP, and just thank you, everyone.
Well, my biggest ask of anybody who is able to do so, pretty please become an ambassador. It again, minimal effort or maximum effort, any effort helps. Pretty please. And I have downloaded the toolkit. There are flyers in different languages. There's stuff you can put up on your social media if you want to. There are all kinds of goodies to just get the word out so that people remain in the know about what's going on. Plus, you will get those direct emails about what's going on from DHCS, and they're really helpful. So, you don't go into work on Monday and it's like, what happened? Why are people like, you will have a heads up. So that would be my biggest ask. And thank you for everything that you're doing.
Thomas.
I agree with you, Dana. I think one thing, my last word is this: all of us can do something.
Yeah.
There is a role for every single entity in the effort of, PHE unwinding and help our resident to, maintain that Medi-Cal eligibility. And it needs all of us, right? The effort needs all of us, because you hear the impact level, 2 million lives. That's a lot. 2 million family. That's significant. So I think all of us can make this happen.
Thank you, Thomas. I look forward to also talking about the family glitch fix, which is more good news on the way. But Emily, I will hand this over to you. Thank you so much, everyone.
Thank you so much, Heather, and thank you to Marion and our incredible speakers for joining us in this important conversation today. We know that this will be a huge undertaking with considerable consumer and delivery system impacts. And as Heather mentioned, you can absolutely expect ITUP to continue to engage in this very important conversation. Thank you again to our audience for joining us as well. I will say take care, everyone. Have a great rest of your week, and we will be in touch soon. Thanks so much.